ready to go live.
You bet. Here we go.
Good afternoon, everyone. I have 2:33. We will go ahead and get started. My name is Ken Sharp. I am a division director here at the Iowa Department of Public Health for the Division of Acute Disease Prevention, Emergency Response, and Environmental Health. We are speaking today to school administrators regarding Iowa's vaccination strategies to give you some information as you plan for vaccination efforts for your school, staff, and teachers in the coming weeks and months as we transition into phase 1B of the Iowa vaccination strategy. With me today, I've got a handful of IDPH staff, Don Callahan, who is the Bureau Chief for our Immunization Bureau, Rebecca Curtis, who is our Bureau Chief for Emergency Response, Emergency and Trauma Services. I should more thoroughly represent Rebecca. My apologies, Rebecca. Bethany Kinty, who is our Immunization Program Manager. And then I do not have recognized on the slide, and my apologies to Dr. Michael Pintella, who is with the State Hygienic Laboratory. So in addition to the vaccine presentation today, we do intend to turn some information over to Dr. Pintella for the Binax Now testing program. We will use the Q&A function. There will not be a voice interactive option. So if you do have questions as we go through the slide presentation today, please use the Q&A function to submit your questions. We will facilitate those questions at the end, and I will moderate the question and answer session when we get there. I will have my team available for additional questions. I think for the simplicity of getting through the slides, most of the presentation will be myself and then Dr. Pintella when we get to the Binax Now testing information. So with that, we'll go ahead and advance to the first slide here. So as I mentioned, the purpose of today's call, particularly as it relates to the vaccine information, is to provide you the most current information we have regarding the allocation, distribution, and administration of vaccines in the state of Iowa. I should make sure that we are very clear. In the last 2 weeks alone, we have seen dramatic changes in the guidance and practices of how we are managing and what we expect to see in terms of changes with the transition to the Biden administration. So I qualify the rest of the presentation with the information that we share with you today may and likely will in some respects change as we move into the next several weeks with the rollout of the Biden plan. So please check back frequently to our IDPH website. The other thing that we would encourage you to do is, if you have not already had communications with your county public health agency, please check their social media, their websites, and if you have not made direct contact with them regarding planning efforts for reaching childcare through 12th grade staff, I would encourage you to do so with your county public health agency. Some key terms that we want to make sure everybody is familiar with. We in public health take these terms for granted, but we want to make sure that you see these and understand as we move through the presentation. There will be some reference to these terms. These are all things that are part of the overall vaccination strategy. One of the key things that we will be talking about in a little bit more detail is the pods, the points of distribution. That's how we see vaccines being administered, particularly when we are targeting specific groups. And we'll explain that in a little bit more detail later in the slide presentation. We want to start with a very kind of high overview of how the vaccine allocation occurs from our federal partners to states and then to the local level. The key thing that we want to point out at this time, and we will continue to have a very prominent role for local public health, is that vaccine administration planning and strategies are at the discretion and the responsibility of the local public health agency. We have one public health agency in all 99 counties, and they are the ultimate decision maker on how and where vaccine allocations are made in the county. So as a state, we really are a facilitator of vaccine allocations, and we provide technical support and information to those county public health agencies as they carry out their plans, but we are not dictating to our local providers how that shall occur. So we do want to acknowledge and just discuss at a very high level the vaccine distribution process. And we want to make sure that folks understand that when we talk about allocation and distribution, this is all done in largely a virtual environment. We also want to make sure it is clearly understood that Iowa does not have a warehouse of vaccine anywhere in the state. All of the vaccine that we receive is shipped directly from the federal government to the vaccine providers that are scheduled to receive vaccine in any given week. So each week, we receive information from CDC and Operation Warp Speed on how much vaccine the state of Iowa is going to receive. And that is something that is directed to us. We do not have the option to order additional vaccine beyond what CDC and Operation Warp Speed has informed us of as our allocation. Another key thing to keep in mind is we look at carrying out the vaccine strategy. Any healthcare provider who intends to provide COVID-19 vaccine needs to complete a vaccine provider agreement for the COVID-19 vaccine. There is on our website under the vaccine provider link an enrollment letter. If schools are interested in obtaining that, they can certainly look at becoming an enrolled provider so long as you meet the requirements of that provider. The other thing that comes along with the enrollment as a vaccine provider, you are making obligations to report the required data elements into IRIS, which is our immunization registry, in order to be eligible to receive the COVID-19 vaccine. That requirement helps us keep track of vaccine administrations, vaccine inventory, and overall vaccination rates. So at a more granular level, I mentioned to you on the previous slide that each week the state of Iowa is informed of how many vaccines we will be receiving in the next allocation, and that is done electronically. So we receive a notification of how many doses we're going to be receiving, and right now that is split between Pfizer and Moderna products. Currently, the state of Iowa receives about 19,500 doses of Pfizer and 19,500 doses of Moderna. Through the end of January, all of the Pfizer product that we are allocated is being committed to the National Long-Term Care Pharmacy Program. And if you have seen recent press coverage, you know that the governor has talked about the National Long-Term Care Pharmacy Program. Iowa, out of our weekly allocation, must fund that program with vaccine. So that leaves us for the last several weeks with only about 19,000 doses a week of the Moderna product that we've been able to allocate to our local public health agencies. Beginning the first week of February, we will see that we have largely satisfied that long-term care national pharmacy allocation. And by the time we hit the week of February 8th, we are projecting that we will have a combined total of about 39,000 doses of vaccine between the Pfizer and the Moderna product. Once we then receive that number, we then at the state level apply a formula-based application to that number of doses, and it's largely based off of population distribution across the state by county. We then identify for each county how many doses of those 39,000 doses that we'll be dealing with in February each week. The county gets a notification from us each week to say, here are the number of doses that you are eligible to receive in your county. And then we ask that county public health agency which vaccine providers in your county should receive the next shipment of these doses. So as local public health then makes that consideration, all local public health agencies in the state of Iowa are enrolled vaccine providers. In addition to those 99 counties, we have another roughly 1,600 vaccine providers enrolled in Iowa as COVID-19 vaccine providers. That local public health agency takes into consideration the number of vaccines that they have, the target population that they are achieving, and who the vaccine providers can reach with respect to that target population. Local public health then makes a decision who will receive the vaccine, and they notify the Department of Public Health on where they want that vaccine shipped. So it can be any combination. Local public health can keep all of it. They can distribute all of it to their vaccine providers, or a combination of the above. Again, we reinforce that in order to receive vaccine through that process, you must be an enrolled vaccine provider. So each week then, we communicate to CDC which of those 1,700 vaccine providers shall receive the shipment of the vaccines that we have for a given week. And CDC and Operation Warp Speed then work with our federal partners, and they deliver the vaccine directly to the vaccine provider. And there are no hands at the state health department level that touches those or manages those vaccines. It's a direct shipment process. We want to then talk about, once the vaccine is on the ground with these vaccine providers, typically in these events, as we particularly are dealing with shortages of vaccine, we want to talk about how vaccines are made available. And it's typically through a points of dispensing, a pod. And those can be very large or very small, and there's a great deal of flexibility in terms of how the counties handle that. Pods, as we've already identified, are community locations where dispensing and administration of medical countermeasures, in this case, vaccines, can occur. And there will likely be two types of scenarios that play out with these pods. One is an open pod where the general public or a population that's identified as eligible, for example, school officials or school staff, can come to an open location, and there might be, for example, an open pod at a centralized location in the county. And if you have 10 school buildings, personnel from all 10 of those school buildings would come through that open pod with some type of identification to let them know. Closed pods are typically very specifically located at a location where, if a school is large enough, they may have a closed pod only for their staff in a large school building or a large school district. And they can be used simultaneously, and we will continue to watch these pods expand in terms of coverage and size as we see increases in vaccine made available in the state of Iowa. We want to talk a little bit through priority groups. There's been a lot of coverage in the last 2 to 4 weeks regarding priority groups. We want to make sure that there's a clear understanding of how that priority groups were identified. Some ground truth, however, right now we all know public demand for vaccine is going to be high, and it will continue to be high for some time. We are also faced with the reality that we do not have enough vaccine to go around, and there is a shortage because of the ramping up the manufacturing process, and right now demand for the vaccine far exceeds supply. So as we look as a state, we have to make some decisions on priority groups that will be based on vaccine supply, the severity of impact from the pandemic on populations, and the potential disruption for community critical infrastructure. As we look at trying to work through those priority groups, the department director, Director Garcia, established the IDAC committee and the Infectious Disease Advisory Council. That group has been meeting since mid-December. They have largely been basing their review and considerations off of the ACIP recommendations that come from CDC. So ACIP is the Advisory Committee on Immunization Practices. It is part of CDC, And then IDAC is the Iowa body that provides further guidance and recommendations to the department director for priority populations. So as I mentioned, IDAC has been meeting for the last 6 to 7 weeks or so to kind of work through those considerations, and they've been reviewing the ACIP recommendations as a basis. So a little bit more about IDAC. They are specifically addressing recommendations for future or further prioritization. They are comprised of clinical and ethical expertise from across the state, including university representation, infectious disease specialists, local public health agencies, and key provider associations that represent vulnerable populations, as well as state agency staff at both the Department of Public Health and other state agencies. In December, specifically on December 21st, there was guidance issued for phase 1A, and that is the phase that we continue to focus on for about another week. We are working on finishing up healthcare personnel and residents of long-term care facilities. So you've seen a lot of media coverage about reaching out to healthcare personnel. The reason we focused on healthcare personnel first, in addition to the long-term care residents, is that we felt it very important as we watched the disease trends in other states across the nation and watched the surge of disease in some of those states, particularly challenging the healthcare system. We wanted to ensure that the healthcare system was stabilized with vaccinated and protected individuals, so that in the event that we have another surge, we can ensure the healthcare system is ready to treat those patients in the event that the hospital system becomes stressed again. The obvious reason for focus on residents of long-term care facilities is that population has been one of the most heavily impacted in terms of morbidity and mortality, and the evidence has clearly showed the impact disproportionately to that population. So we felt it was important to vaccinate that population early and establish some level of protection in that population. In the last week, so a week ago today, on January 15th, there was an initial issuance of an additional vaccine shortage order that laid out phase 1B. That has been changed as of yesterday because of additional changing information from our federal partners. And I won't go through the details of why all of those changes have occurred, but I will spend a little bit of time walking through the phase B vaccine shortage order that was issued yesterday. If you want to see this document, it is posted on our department webpage. If you go to the COVID-19 webpage and then further dive into the vaccine webpage and then go to the vaccine provider tab, there is a location on that webpage that includes this shortage order. So this shortage order was modified yesterday, and it includes kind of a two-pronged approach. First is throughout the phase 1B, the population aged 65 and older will be eligible to receive vaccine during phase 1B. And at the same time, there are these other high-risk populations or at-risk populations that we will also be vaccinating at the same time. However, in order to try to better balance the supply of vaccine with the demands that these populations will place for that vaccine, there was a decision made that there needed to be a tiering of these groups of individuals to help local public health prioritize and communicate to the public about who can expect the earliest doses of vaccine and who should be patient and wait for later doses. So particularly for this webinar, it's important to understand that in Tier 1 are our first responders and our pre-kindergarten through 12th grade staff, early childhood education, and child care workers. The key thing that we need to have everyone understand, when we look at the population 65 and older, there are about 530,000 individuals in that population. And when we look at the total population for first responders and school staff, childcare workers, etc., there are approximately an additional 130,000 individuals in that population. For important context, recall, I believe I provided you some idea that when we get into February, we are expecting 39,000 doses each week. So it's going to take us a little bit of time to get through roughly 600,000 individuals that are currently combined between the age eligibility and the Tier 1 group. I won't go through explicitly the additional tiers, but understand that we will be moving into Tier 2, 3, 4, and 5 as we wrap up the Tier 1 vaccination efforts. So we want to make sure that you folks understand that as your schools look to local public health for vaccination options, that the vaccine supply is going to continue to be slow and not meet demand, and it will take local public health some time to be able to get all schools vaccinated. The other thing that we also need to understand is we are waiting guidance from the Biden administration on how and whether they will change their allocation process. And we are waiting on additional guidance as to whether the manufacturers will be able to significantly increase manufacturing of the vaccine as we get into February and March. In addition to that, there are additional considerations at the federal level for activating a retail pharmacy program where doses would be allocated directly to national retail pharmacy chains, and we have about 24 of those eligible pharmacy chains in the state of Iowa. So there are a lot of variables here that will impact the accessibility and the timing of when schools across the state will be fully vaccinated. So we want to make sure folks understand that there's going to be a need for ongoing patience and understanding as we work through this until we have better clarity of what the vaccine allocation numbers will look like. So what can I do now? As I've just stated, really the simplest request that we have is please remain patient. We have a lot of very difficult work and decisions being made at the local level. Local public health systems are very challenged and stressed right now, but we do recognize we are at a time where local public health and schools need to be talking about what this transition to phase 1B looks like. We will see, as I mentioned, vaccine supplies will remain low, and we will hopefully in the next 2 to 4 weeks have better clarity on how that vaccine supply may improve. We would also suggest you continue to monitor our website at the Department of Public Health. There is some very high-level information that is available there. If you're interested in watching administration rates, if you go to the coronavirus.iowa.gov website, that has been up since early in the pandemic, where a lot of our epidemiology data and hospital data has been posted. There are some new images and new pages that are being developed currently that should be available soon on that coronavirus website. Another key important factor is if you have not yet engaged with your local public health agency, look for information. We've got a tremendous amount of efforts coming out of local public health using their own social media, their websites, and other communication methods. And if you have not made that connection with your local public health agency, I would suggest a phone call in the next week would be a good opportunity to build that relationship. If you haven't already started, we think it would also be beneficial for those local public health agencies in working with you if you had some information pulled together regarding the number of staff, and this is not just teachers, but truly all staff in that PK through 12 setting. If you had total numbers, and then what we're also hearing from local public health is it is beneficial for them to hear from employers if the employer has surveyed their employees to understand how many are interested. Just because you have 100 employees doesn't necessarily mean that all 100 are going to want the vaccine. And if we were to learn that only 60 of those employees would want the vaccine, it's very important for local public health to know that, so that as they work to schedule their clinic, they're not running into a situation where they're risking wasting vaccine. So those types of details that you can start working on now, if you haven't already done so, would be very beneficial. So this is the next most common question, regardless of the population that we are talking to. When and where will we get our vaccine? We want to make sure that everybody's very pragmatic and understanding the phase 1B population, even in tier 1, will likely take several weeks across the state. Phase 1B as a whole, when you take all 5 tiers, will likely take us several months, absent dramatic increases in vaccine availability. As I've stated here in the second bullet, vaccine supply is the biggest barrier right now for us to move forward with vaccine administrations. And as soon as more details regarding the availability of vaccine and how it impacts the timeline, we will be sharing that information with the public through the governor's press conferences and through communication with local public health. So as we had alluded to earlier with some of the pod discussions, we want to just give schools kind of an opportunity to think about where they may be achieving their vaccine strategies. If you're a large school and you want to, or a school system, and you're interested in trying to get your entire population vaccinated through a 1 to 3 day clinic, that's certainly something you should be discussing with your local public health agency. It is certainly an option. There may be a situation where local public health is offering, for example, a single clinic for all school workers and staff, and they may be having that centralized out of a central location in the county. And then there are options where, for example, if there's a relationship with a pharmacy that would be willing to provide that vaccine to school employees, local public health, the pharmacy, and the school can work together to have a third party offer that pod dispensing for that school population. So at this point, I'm going to turn over to Dr. Michael Pentella with the State Hygienic Laboratory. He's got just a few slides regarding the implementation of the Binax Now cards. And there is perhaps a slight delay, so be patient with us if we have a moment of pause here until Dr. Pentella is able to join us.
Can you hear me, Tim?
I can, thank you.
Very good. Thank you all. Thank you for giving me a minute of your time this afternoon. I wanted to let you know about the expansion plans to provide Binax Now testing that will impact the K through 12 population. If we can move on to the next slide, please. And there's a pause because I'm out of sync. But in our efforts so far to get the Binax Now antigen cards into the hands of people in the community, we have seen them going to long-term care facilities, about 80%, and 20% to locations that provide testing for K through 12 population. These are pre-assigned clinics that have volunteered to provide this testing. If you go to the next slide, in the next 3 months, Iowa is going to be able to purchase an additional 76,000 cards per month, and a total of 228,000 cards. And we want to be able to expand testing to help the K through 12 schools be able to open confidently so that there is not further infections with COVID-19. We don't know if in the future the Biden administration will allow us to continue to purchase these cards, but we know for sure at this time we can do so for 3 months. And we also do have some back supply that we can call upon as well. On the next slide, this describes the K through 12 expansion. We're going to reach out to all of the clinical labs throughout the state. We've already placed these in 85 clinical labs throughout different counties in Iowa. Now we're going to just make it open to all clinical labs with the idea that they'll make this testing available to K through 12 students and provide a rapid result. On the last slide, we're describing the further use of this testing capacity, and that will be for some colleges and universities and free clinics, adult daycares, visiting nurse services, and other home health. So we're hopeful that this will be part of the overall plan in support of opening up the schools and keeping COVID-19 out of your facilities. And I'll stay on in case there are any questions. Thank you.
Thank you, Dr. Pintella. I appreciate your time today and sharing that information. Okay, so that comes to the end of our slide deck. I will just remind participants, if you do have questions or seeking additional information, please enter your questions in the Q&A, and we will work our way through those questions. Right now it looks like there's a little bit shy of 20 questions, so I'm just going to go ahead and moderate those and work through those questions as they were received. And feel free, as I say, to add questions at any time during the remainder of the webinar. So the first question is, do we know how much will be distributed in to the individual providers? If not, when will they be notified of their vaccination numbers? It is nearly impossible for us to predict what an individual provider will be receiving any given week. As I shared with you earlier, the numbers of vaccine doses that we are receiving when we hit the February timeframe are only going to be about 39,000 doses. We are, and that's each week. We are awaiting additional guidance from our federal partners about what increase in manufacturing is scheduled to occur in February and March, but we do not have any levels of assurance of what that number is. So as we begin to allocate for doses that will be shipped into the state of Iowa the week of February 1st, we are resetting our strategy to ensure that all counties receive some doses to start their vaccination efforts for the phase 1B and tier 1 populations. So if you just do some basic math, the number of doses can be as small as 100, and it might be as many as 1,000, but it will be some combination thereof, and it will be not enough to make a real great advancement in the first week. The other thing that is at play is that there are doses that have been allocated and are continuing to be shipped each week prior to that February 1st timeframe. Those doses are finishing up the phase 1A population, particularly healthcare providers. And what we have done in the shortage order that was issued yesterday is to offer some flexibility for vaccine providers to begin using those doses that they have left over from their 1A efforts to begin working on priority populations even ahead of the official turn-on date of the February 1st timeframe. So unfortunately, we do not know. Counties typically will have less than a week's notice of how many doses they are receiving from the time that they are notified until the time the doses arrive. And they will be working directly with vaccine providers in the county to notify them of the number of doses that they will be receiving. So there's a comment. Iowa Public Radio yesterday or today mentioned that Iowa ranked 46th in the country on received doses. Why is that so low? We are asking the same question. We don't have an understanding of that ourselves. We are continuing to work with, and my staff are on regular phone calls with Operation Warp Speed, Health and Human Services, and CDC, and we are seeking additional guidance as to why that is the case. We hope to see an increase as a result of vaccine manufacturing production in the months of February and March. So then the next question is, Iowa's AEAs have staff working in K through 12 settings in all 99 counties. Can IDPH help this issue by explicitly referencing AEA staff as K through 12 educators? We have received that question a handful of times, and we agree with you. AEA staff that are working in those PK through 12 settings are eligible. We are working on a Q&A document, and we will share that with our local providers to help them understand that the AEA staff working in that PK through 12 environment are eligible recipients. Can a school fill out the enrollment letter to be a vaccine provider for the school? Bethany or Don, can I turn to you to just cover at a very high level the criteria that it takes to become a vaccine provider, please?
Yeah, thanks, Ken. Pretty much the school would have to have a physician supervisor, so you would have to have a medical director for your school to be able to enroll as a COVID provider. In addition, you would have to have the ability to appropriately store the vaccine. The vaccine that we are receiving right now that you probably would receive would be the Moderna vaccine, and that's stored either at a negative 20 degrees Celsius in the freezer or at 2 to 8 degrees Celsius for 30 days. So I think the biggest barrier that may occur for schools is that you would need to go ahead and have a vaccine or a medical director in order for you to become a COVID provider.
Great, thank you, Don. The next question is, will a teacher who has already tested positive be eligible for the first wave of vaccines? We would ask that teacher to be thinking about, because of their illness, they will have some antibodies for some period of time, and we would prefer to focus our vaccine efforts on those who have not tested positive. Bethany, as our immunization nurse and immunization program manager, will you weigh in on any additional guidance that you have for this question, please?
Absolutely. CDC has no minimum interval between vaccination and illness. What we would just ask is that you are through your isolation period, just because we want to protect our healthcare workers. But as Ken indicated, we know that reinfection is likely not going to happen within those first 90 days. So you can choose to be vaccinated towards the end of that 90 days.
Great, thank you, Bethany. So the next question is, I have heard that 20% of the people who receive a vaccine have a reaction. Can school staff be vaccinated on a Friday afternoon or Saturday to avoid large absence rates of staff? Bethany, again, I'm going to turn back to you for a response on that question, please.
Absolutely. The majority of the side effects that we're seeing from Moderna are sore arm, redness at the site, a slight fever. This is something you definitely can talk with your local public health or the pharmacy when they are scheduling your vaccination clinics to discuss options that you have to ensure that you guys do not have staff out the following day.
Great, thank you, Bethany. So there's a question here regarding the, there's a bill. I'm just going to be very candid here. We have had our heads so far into the books on vaccine allocations. I haven't looked at the bill that is being drafted or being considered on Monday. So the question is, are we considering that teachers and school administrators may need to be going full-time into classrooms without the ability to social distance? There's concerns about that for educators. Melissa Walker, I believe you have joined us. Is there any response or any guidance that you have in response to that? And if not, I certainly understand. We are not aware of the details of that bill at this point. Okay, Melissa may have, oh, is she there yet?
Yeah, Ken?
Yeah, now I've got you, Melissa.
Hi, this is Melissa. I would defer that question to the Department of Education and we can get a response.
Okay, very well. Thank you, Melissa. Appreciate that. Is 1A vaccination complete? We are very, very close, and we are hearing from a large number of counties that they have completed their 1A population. Where it is not quite buttoned up is in the largest population centers. For example, Polk, Johnson, Lynn, Scott are some of the typical counties that we are hearing, excuse me, are still wrapping up that 1A population. And they are telling us they will be essentially finished with that population by February 1st. Are substitute teachers in the PK through 12 school staff? Yes. Again, anyone, whether it's substitute teachers, whether it is student teachers, or any level of staffing in that PK through 12 environment, is and should be considered eligible as school staff. Should schools look at a priority group within their system to assist local public health? That's a question that we received from local public health as well. From a practicality standpoint, this is similar to a question that we receive from national pharmacy chains regarding when they go into long-term care settings that have multiple levels of service in the same campus. I think at this point, because we are very interested in making sure that schools are stable and able to accept children in the classroom, we do not feel it is necessary to sub-prioritize. The only exception to that may be is if there are extremely limited doses, perhaps it does make sense to do that. Or in those situations that were described earlier, if you have a teacher or a group of teachers that have recently been ill, they may consider delaying the vaccine until it's more widely available. So the next question is, will the second dose be administered to Tier 1 people before moving on to Tier 2? At this point, no. Our intention is that as we receive allocations, and the strategy that we have seen from the federal government to date, is that when they allocate doses to the state of Iowa, they hold an equal number of doses back and ship those doses to us 21 to 28 days later, so that we can ensure the timing of that vaccine. The only thing that's an outstanding unknown here is the Biden administration has indicated they may change their strategy on holding back that second dose, which may allow us to vaccinate more individuals the first time through, but it does raise some questions on how we ensure that second dose is administered. So for the purposes of moving from one tier to the next, no, those in Tier 1 do not have to be fully vaccinated with 2 doses before we move to Tier 2. Does Tier 3-2 include state staff working in state agencies? Okay, no, the short answer to that is no. The government employees that were identified were specifically those that are working in the state capitol, and that was largely in response to the decision to not require face coverings. There were a number of staff who are required to work in the building every day that really don't have an option to social distance. And so this was really targeted at a very narrow population of government employees who have required business in the Capitol that cannot otherwise be dealt with from remote options. The next question I see here is, why is Hy-Vee in Des Moines giving vaccines for 65 and older right now, while others across the state are not receiving these shipments, especially to the tiers listed? This is where we are in a transition period. As I mentioned to you with the transition that we had yesterday, there is the ability for some vaccine providers that have extra doses left from the 1A effort to proceed with vaccinating those individuals 65 and older ahead of the February 1st timeline. We will be stabilizing the allocations, as I mentioned earlier, beginning the first week of February, so that every county in the state, when we hit that February 1st timeframe, will have an allocation coming to them on a weekly cadence. Next question is, can local public health prioritize within their Tier 1, or will teachers in all areas of the state have access to the vaccine at the same time? Just the very pragmatic fact that we just simply don't have all of the vaccine that we would like to have. There will be variations in county to county timelines for what populations they are accessing and how quickly they move through those populations. So while we did very intentionally as a state try to keep everybody focused on statewide application of the phase 1A population for vaccination purposes, we feel at this point the important piece is to ensure that we get as many people vaccinated in these priority groups as quickly as we can. And in order to do that, we need to offer counties and vaccine providers some flexibility to move through those populations as quickly as we can without the burden of having to redistribute vaccines from one provider to the next. If a school district wants to partner with a pharmacy to set up a vaccination clinic for school staff on district grounds, does the district enroll as a provider through IDPH, or would it be done by the pharmacy? It's the individual providing the vaccine. So in this case, it would be the pharmacy, and chances are that pharmacy is already an enrolled provider. Dawn and Bethany, I'm going to pause here in case there's anything else that you want to add to that question.
You are correct, Ken. That's how the enrollment should work. But also, you're going to want to go ahead and work with your local public health agency to make sure that they're aware of that arrangement, that that pharmacy will be coming to your school. That way they can allocate vaccine for your population.
Thank you, Don. Dr. Pentella, the next question is for you. Will schools be receiving the Binax Now cards? And if so, how?
No, these cards will be going to local clinical laboratories. So consequently, you won't be receiving the cards directly. But you'll be able to know, and we'll make sure the information gets out, where those clinical laboratories are located so that you'll know where the students can go to.
Thank you, Dr. Pentella. The next question, I'm hoping you can help with again, Dr. Pentella, and I don't have any of our epidemiologists on the call to help answer this, but if you can answer this question, that would be great. If not, we will have Dr. Garvey and her team provide a response at a later time. Will the Binax testing change the IDPH algorithm where we need to retest a negative Binax in 24 to 48 hours with the PCR test?
The recommendation to repeat the test in a asymptomatic individual or a symptomatic individual will stand. So as we have now, as IDPH has put out, if you have somebody who is symptomatic and tests positive, you don't need to repeat the test. But if they're asymptomatic and test positive, the recommendation is to repeat the test with a PCR test to confirm that it's a true positive. As the tests were designed not for using with asymptomatic individuals. Consequently, you're at risk with the asymptomatic of getting a positive that's not a true positive, and that's why that recommendation is made.
Okay, thank you, Dr. Patel. I'm going to give you a one question break and then I'm going to come back to you. So the next question that we have is, do you foresee that you will open up Group 1B the first week of February, or will it be later? No, to be very clear, the 1B population, so that is 65 and older, and the first tier of the 1B population will be eligible to receive vaccine beginning February 1st, regardless of where we are with vaccine allocations. So there are some exceptions where some vaccines may be given ahead of that, but those are going to be a little bit unique and not necessarily commonplace. But yes, everyone in Phase 1B 65 and older and in Tier 1 of Phase 1B will be eligible beginning the week of February 1st. So Dr. Pentella, the next question, just a clarification, does the school need to have a CLIA certificate and trained staff in order to perform antigen testing, and would positive results need to be reported in a certain way?
If the school were doing the testing, yes, you have to have a CLIA certificate, trained staff, competency, etc. And also all positive and negatives have to be reported. That's one of the reasons why we're going to the clinical laboratory community, to reduce the burden on schools for having all this put in place. It gives the eligibility to have the testing, rapid results, rapid reporting to IDPH, and it makes it easier throughout the state to manage the program.
Okay, Dr. Pentella, I have a couple more for you. If a person is symptomatic and being tested with the Binax Now card, do they need to retest with a PCR test if the result is negative? Can you offer additional guidance and clarification on that?
If the person is symptomatic and they test negative, yes, it's wise to get a PCR test to confirm that it's a true negative.
Okay, thank you, Dr. Pantella. The next question I think is for you, and I think it's seeking a list of the clinical locations where the Binax Now testing capabilities exist. Is there a list, and how might folks access that?
We have given a list to local public health, so they will have the current list of the 85. We are reaching out to more clinical labs, and we will give that to local public health to distribute among the school districts. So this will be a couple-week process to get all the updated list information.
Okay, thank you. The next question, Dawn and or Bethany, I'm going to turn to you for guidance. Will the state allow school nurses additional IRIS access as a way to provide more flexibility for a district that would like to serve as a closed pod? Without this increased access, it's extremely difficult for a district to serve as a closed pod. Can you address that question, please?
Yeah, thank you, sir. So if a pod is being conducted by another organization, that organization will be responsible for doing the documentation in IRIS. That is necessary so those doses are deducted from inventory. However, if a school does enroll and has a medical director and they are able to become a COVID-19 vaccine provider location, then you will have access to document your own doses out of your vaccine inventory.
Thank you, Don. Bethany, the next question is for you. Is the vaccine recommended for a mother who is nursing?
So there was a lot of discussion at the ACIP, and the studies are ongoing for safety, but the two vaccines that we currently have, Pfizer and Moderna, are mRNA vaccines, and they are not thought to be of any risk to a breastfeeding infant or a mother who is lactating. So if the person who is breastfeeding is part of the priority group, we do recommend vaccination. However, talk it over with your healthcare provider. They're your best resource. And then the CDC really has a nice webpage that really goes through step by step to provide some good information.
Great, thank you, Bethany. Next question is, can we get a copy of the slides? This webinar is being recorded and will be posted to the IDPH website, and I would be happy to share the slide deck with our Department of Education colleagues who can send this out to you if you want to reference the slides. The only qualifier I will just state, as I stated earlier, please understand some of the information in these slides may be dated in a very short amount of time. So if you plan to reference these slides, I would ask that you please kind of verify the information as still accurate, particularly if you're talking with community members or your staff in the event that additional information changes. So the next question is, do we know which vaccine we would be receiving, or will we know? I'm not sure I understand the intent of that question, but I think in either case, if you're asking that from the question of a vaccine provider, yes, you will know which vaccine you are receiving. If you are talking about that question in context of a patient, the answer is also yes. Don, I see you've come off mute. You or Bethany want to add any additional context to that question?
Yeah, Ken, you're 100% correct. Also, when you receive the vaccine, you will receive a immunization card, which will document the vaccine type that you received and also the recommendation when you should come back and get your second dose. So that information or those cards are being provided with each vaccine shipment, and they are included. So every vaccine recipient will receive that card with that information. In addition, IRIS will have a documentation of all the vaccines that are administered. So that will be in IRIS. That'll be a permanent medical record, and you can always retrieve that information for the vaccine that you've received.
Thank you, Don. Another question, Bethany, for you. Is infertility linked to the vaccine that you are discussing for this group?
This is a question I receive at least several times a week. If you go on any social media, you will see articles about this. I encourage you all to make sure when you're looking at articles that they are scientific in nature. There is no data out there that links infertility in COVID-19 vaccine. The safety studies are ongoing. There is also a V-Safe program. Once you receive the vaccine, We encourage you to sign up for that. CDC monitors that, so any woman who is pregnant that has received the vaccine, they are continuing to follow them, but no, there is no link.
Thank you, Bethany. I think I'm going to give the next one to you as well. If getting the vaccine and a child at home becomes positive or someone in the home is positive, do you still have to quarantine?
I think Dr. Padati would tell you at this time, yes, we are still recommending quarantine. I do think, however, as we have more vaccinations complete and we have people having immunity, I think this will be up for discussion. I think CDC is also looking at this as other states around us.
Great, thank you, Bethany. There's another question on here regarding donations of convalescent plasma for a COVID positive. I think we will defer that question to our medical team and work to provide an answer back to you that route. Dr. Pintella, the next question is for you. Is the testing with the Binax Now cards free for K through 12 students?
The product is free to the clinical laboratories. They may charge a testing fee for their personnel time. So that is up to the facility and what they decide to do.
Thank you, sir. The next question is, if my county isn't vaccinating teachers yet, can I go to a neighbor county that is? The simple answer is yes. The more appropriate answer is we would ask you to please be patient and work with your county as much as you can. What we don't want to have happen is a lot of shopping around a vaccine. The vaccine is in very limited supply. And as counties are working through their plans and trying to work on some level of precision for vaccine clinics, it makes it much easier for them to manage that vaccine inventory if they have a clear vision of the vaccine supply that they need to have on hand to meet their population. The next question is, who does someone 65 or older contact to get their vaccine? Public health, local public health. Our recommendation at this point is that 65-year-old or older individual we would suggest a couple of considerations. First, watch for social media through the county health agency. That may give you a good indication of whether the county health department is planning an open pod clinic for that population, or if they are driving that vaccine to targeted locations to a particular pharmacy, for example. So I think checking the local information from the county health department on what their vaccine allocation strategies look like will be important. The next thing that individuals can do that are in that age population is to reach out to their healthcare provider or their pharmacy. And if those individuals or those locations do not yet have vaccine, I would ask if those providers are taking names on a wait list that can be used to notify candidates at a later time. So the next comment is our local public health department is awesome. That's great to hear, and is communicating and updating on a regular basis regarding the tiers, but we'd like to know if there's any way to get a more accurate amount of vaccine that will be available to our school district once available. We just simply don't have that luxury at this time. What we can only tell you is 1 week in advance, roughly, of the vaccine that we know we will have on hand. We have tried early in this event in December to make some projections, and we were burned on that a number of times, either in the negative or in the positive. And so it just, at this point, we do not have a level of certainty beyond what is coming for the next week. And so I know that's incredibly challenging and frustrating. It is a real reality that we are facing, and we are getting this question from every local public health partner that would love to be able to say what's my vaccine allocations going to look like in 1 month so I can begin planning. I'm sorry, we just do not have the luxury to offer you that level of detail at this point, and we will continue to update if we do get to a point where we have that level of clarity. The next question, is there a standard scheduling system that local public health or pods will be using to schedule vaccines? If the question is there a centralized state scheduling system, the answer is no. However, IRIS does have reminder recall capabilities for reminding people when to come back, but it does not have scheduling capabilities. So, however, I will say that our local public health agencies that are working with their local partners are leveraging relationships with pharmacies that have scheduling systems. They're leveraging relationships with healthcare providers that have scheduling systems, or the counties themselves have purchased scheduling systems. So unfortunately, there is not a single statewide centralized scheduling system, but most counties are using one of some form. Can our local hospital give the school employee vaccines in a pod, or should it be done through local public health? That again will be a county by county decision. It would certainly be appropriate if the county works with that hospital to serve as a vaccination site for your school employees. It is also perfectly appropriate for that county public health agency to offer a clinic through their entity to do the same. So again, this is where your conversations with your local public health agency are vitally important. Okay, that is about the end. I'm just going to take another quick peek at a few other questions here. So there's a suggestion made that if you're talking to staff about their interest in vaccine, to include some demographics, name, date of birth, phone number, email. That is something that public health will use in their respective systems, and it will help save some time perhaps on the front end. That's a reasonable recommendation, and certainly part of that information collecting that you can take part in. How is IADPH communicating with the legislature, teachers, bus drivers, food service, etc., not be subjected 100% in person? So this is more of a policy issue on 100% in person versus hybrid models. We are certainly answering a lot of questions about risks in those environments, and certainly responding to those requests for information when we're getting them. So more just really statements and comments on legislation. So I'm not going to try to address those. Not really in a position to speak to policy level items. Just taking one final perusal. I think we have made it all the way through the questions that we have received to date. So I'm going to pause for just a moment. I'm going to check in with Dawn and Bethany. Rebecca, if you are still with us, any additional information that you feel we should share with this audience today?
None at this time. Thank you.
Thanks, Bethany. Okay, hearing none. Dr. Pintella, I'm going to turn to you for one final opportunity for additional information.
I think we've covered it all. Thank you, Ken.
Okay. Bethany, I do have one final question that I am accepting, and I'll ask that you address that. At what point can we consider someone immune after the vaccine? In other words, if someone has had their 2-dose series, and it's 2 weeks later, then they are exposed, can we not quarantine them? Can you address the guidance that we have so far?
So I'm going to address the two parts to that question. After your second vaccine, we know that it's going to take about 10 to 14 days for you to build your full immunity. At this time, we are still recommending quarantine. CDC is still looking at the guidance, the vaccine transmission or COVID transmission with the vaccine, herd immunity, all of that. And so I do believe guidance will be changing. I don't believe it's going to be next week. So stay tuned. But at this time, after you're vaccinated, we still need you to wear masks. The vaccine is just one of the only tools we have to slow this down. We still want you to social distance, and we still will be quarantining with an exposure.
Thank you, Bethany. I see 2 more questions have come in. I'll go ahead and entertain those since we still have a little time on our schedule here. This is a good point. The commenter is suggesting that teachers individually do not call their local public health officials. I fully support that notion. Local public health is overwhelmed, and we don't want to overwhelm them with dozens or hundreds of calls from individual teachers. The audience of this webinar was intended for school administrators, and so that's an excellent message to carry back to your staff. And we would ask that a school representative is the only one reaching out to the local public health to help streamline and coordinate that messaging. And then the final question I see at this point, if the district spans several counties, will we go through just one of them for our teachers? My recommendation is that you start with the county where your base of operations or your central location is operating from. And then from there, I would suggest those counties will have a pretty good idea of what their neighbors are doing. This will vary from one county to the next on how the final precise answer is given in terms of how it is handled. But I would start with your main county of residence, if you will, for the school, and then begin to work out from there. Okay, with that, I don't see any additional questions coming in. I do appreciate everyone's time today. This, as I mentioned, webinar will be available. We will likely have this posted on our IDPH website on Monday. And we will also share the slide deck today with our partners at the Department of Education so that they can share those with you as well, with the caveat that please check for updates before reusing those slides in any public manner. With that, thank you all very much. Have a good day, and we will be talking soon.